Hello, everybody. Thank you for tuning in. My name is Dr. Gabriel Corral. Today, we're going to review a few details in preparing for an intestinal vaginoplasty. Hopefully, after reviewing this video, you'll get to understand what it takes to prepare for an intestinal vaginoplasty and some of the goals and details surrounding the procedure. Let's begin. So, the first question that most patients ask me is, how do we avoid complications? I think everyone coming into having a large surgery like this one, you want to make sure that you do everything that is in your power to avoid complications. And there are a few things that you could consider doing before moving on with surgery. The first and most important step is exactly what you're doing right now. Is preparing for surgery by understanding the procedure and reviewing any type of education material that your surgeon may provide you. This may be done through a pamphlet and a brochure, instructions, videos, and as well as, just discussing with other friends and people who have undergone a similar procedure. So one of the things that we do during the consultation is to make sure that we provide you with all the necessary information so you can make an informed decision about an irreversible procedure. Another important step in the discussion is understanding a clear communication between you and your surgeon about what are those expectations and why is the reason why you are preferring or considering an intestinal vaginoplasty versus other types of vaginoplasties, and really weighing the risks and benefits. Because, like we discussed before, not everybody has the same goals and expect to have the similar outcome. Additionally, in preparing for surgery, you may be required to discuss this with other specialties, such as, mental health provider, perhaps endocrinologist or internal medicine, if there's any other specialists. Many centers like ours will refer you to pelvic therapy as well. And if there are any other types of ongoing issues, perhaps things on the urologic arena, such as urinary incontinence or other issues, then a referral to a urologist will be also be made in preparation to the surgery. Then we have to discuss with the patient as well, what are those long-term goals? Because the recovery process may be 2 to 3 months, but what are those goals that you want to achieve long term? So it is important to have a clear communication. And also another important topic is about sexual well-being. What is expected to undergo after this procedure? What sort of sensation you expect to have in the clitoris? What sensation is expected to have in the vaginal canal? And having a clear communication, asking all those questions during the consultation would be really helpful in preparing you to have a successful recovery time. So let's go in a little bit further and understand some of the vaginoplasty surgical goals are to create a functional vagina. And this is done by making sure that not only has a canal, but has the ability to urinate with an anterior place urinary stream. You want to make sure that the clitoris has adequate sensation. Aesthetic outcomes are also important. I think no one coming into this procedure wants to have an inferior aesthetic outcome. So being able to achieve those aesthetic outcomes, and we have discussed in other videos about the differences between a circumcised and an uncircumcised patient. What are the implications of those changes into an aesthetic result? Preservation of sensation, I think that is important. I think clitoral sensation, for the most part, is also well maintained. I think sensation changes do occur in the skin and in the vulva, and it can take 1 to 2 years to fully come back. But vaginal canal sensation is also something that we don't discuss very frequently. Historically, the sensation in the vaginal canal, if it's an intestinal or peritoneal vaginoplasty, it comes from the pressure and the receptors around the levator muscles in the canal. The canal itself doesn't have the same sensation, doesn't have those erogenous sensation that we see in a cis female vagina. The prostate is very close to the entrance of the vaginal canal, so the prostate is a very erogenous organ. There's some discussion that preserving penile skin versus not preserving penile skin may provide you with better sensation. But the reality is that, yes, there could be some receptors of sensation on the penile skin, especially with pressure and light sensation. But in general, a lot of the times, Many patients don't have enough penile skin to even reach the vaginal canal, and for these reasons, an intestinal or peritoneal vaginoplasties have been discussed. Urinary function, as we discussed, want to ensure that the patient can urinate comfortably with a well-positioned urethral opening. The distance between the urethra and the clitoris also is very important. And we do all of these important four goals to reduce the patient's dysphoria while minimizing scarring and complications, and hopeful that we can meet the patient's expectations during this process. So before your consultation, you got to make sure that you're researching the procedure. Familiarize yourself with different types of vaginoplasty and the potential outcomes. Again, there are multiple videos on our YouTube channel that can take you through this process on each procedure. Make sure that you're very clear about your medical history. Be ready to discuss any previous surgeries or medical conditions or allergies that may have an implication. Even something as simple as an allergy to tape should be discussed prior to surgery, as we sometimes do have a significant use of tape during the procedure. Mental health preparation is important. Many patients need to understand that they are healthy, they're ready to move forward from a physical standpoint. But what happens if after surgery you have more difficulty coping with the surgery? You don't have the support perhaps that you thought that you were going to need from a family perspective or friends. And this can be a little bit of a disappointment and a rough time. So partnering with your mental health provider, not only to obtain some of the letters that are required by your insurance company, but also make sure that you have an appointment to see them right after surgery, perhaps the first few weeks after surgery, as many patients can develop a little bit of the post-op blues. It does tend to improve a little bit over time. If your surgeon stop your hormone therapy, that may also affect how you're feeling after surgery. This is very normal. We don't no longer ask patients to stop their hormone therapy to prevent this, but regardless, even if the patients continue their hormone therapy, being adequately supported after surgery is going to be probably the most important thing from a mental well-being standpoint. You also need to have realistic expectations. You need to understand the recovery process and that everybody's a little bit different. Make sure that you are very respectful of the recovery timelines. If we're recommending you to take 12 weeks of recovery, please take away the 12 weeks from work. Returning to work can also bring you some difficulty with healing and increasing other complications that could be avoided by taking the necessary time. You can also prepare some list of questions. If there are questions that are not listed in the videos or are specific to your condition, make sure you bring those during the consultation, as it's very easy to get distracted during the consultation and forget to ask all the hard questions at that time. Sometimes many health centers have a patient portal which we can submit those questions ahead of time. We do, and we love to have questions ahead of time as well, so that way we are all prepared to give you the best consultation we can during that encounter. And again, insurance is also a tricky point in this process. So make sure that you contact your insurance company, make sure that you have coverage for gender affirming procedures. Some insurance companies do ask you to have an out-of-pocket cost, but it is very variable between each insurance provider and everybody's plan. So some of the options for vaginoplasty reconstruction, as you can see here, there's a penile inversion vaginoplasty, there's a peritoneal, and today we're going to talk about intestinal vaginoplasty options. Primarily talking about the sigmoid vaginoplasty, as the jejunal vaginoplasty will be reviewed in a different surgical video on our channel. Some of the benefits of an intestinal vaginoplasty, as we know, that is a proven method that has adequate lubrication. It can be used as a primary option or as a salvage option. The intestinal vaginoplasty generally does not tend to collapse or stenose as easily, but they can develop introital stenosis. So the connection between the skin and the intestinal mucosa can narrow and form a ring of scar tissue leading to complete closure of the vaginal canal. And although the rest of the vaginal canal may still be open, that entrance is closed, which can make it very difficult for dilation. So again, with an intestinal vaginoplasty, if you make the decision to move forward with this option, you need to make sure that you understand that dilation will always be necessary, because you cannot let the vaginal canal completely close at the entrance. Otherwise, the mucus that is producing will not be able to exit the canal, and it will accumulate and can cause significant problems and creation of what we call a mucocele inside the vaginal canal. So dilation will be really important to avoid accumulating that mucus and allow the mucus to be properly cleansed from the vaginal canal. Some of the disadvantage, as you know, is that it's an abdominal surgery that requires an anastomosis of the GI tract. So in order to remove a portion of the intestine, the other two ends have to be connected. And that connection, that anastomosis, to have the possibility of having a leak. That leak rate is approximately about 1%. Now, another disadvantage also is for some patients is that the lubrication they thought that they wanted prior to surgery, now it's a little bit too excessive. And after trying douching, dilation, and probiotics, for example, which could tend to help with the mucus production can still be excessive from patient to patient, as this is a very variable thing. So this is something to consider, because if you are someone who produces a significant amount of mucus, that mucus is going to require a little bit more upkeep with dilation and with douching to prevent any odor or any problems with the drainage of the mucus. There is a risk of prolapse, which is something very specific to this type of vaginoplasty, and we'll discuss in a few more slides. And then cancer surveillance is also something to consider as well, especially if you have any family risk of colon cancer. To date, there is no studies looking at inflammatory bowel disease and as a contraindication for intestinal vaginoplasty. We have had several patients with inflammatory bowel disease, which we have evaluated prior to surgery with colonoscopy and determined that their disease was very mild, and have done intestinal vaginoplasties with good outcome for those patients as well. So it's not a full contraindication, but needs to be thoroughly evaluated to see if you're a candidate. So pre-surgical preparation after surgery, you want to make sure that you're staying in town for about 3 weeks to make sure that you can come in for your appointment, especially if you're from out of town. One of the benefits of the intestinal vaginoplasty is that no hair removal is required because there is no hair follicles in the conduit. Make sure that you discuss with your surgeon any history of colon cancer, inflammatory bowel disease, or abdominal pelvic surgeries. Most patients who have undergone revisions at a different locations, we generally ask them to undergo an MRI of the pelvis. Some of them need a colonoscopy, and there are other studies that we use to ensure that we can provide a safety salvage after their initial surgery. Other considerations is that you'll probably need to have a bowel prep prior to surgery, and this is really not something fun at all. But prior to surgery, you'll be provided with instructions. We absolutely recommend stopping all nicotine products, vaping 6 weeks prior to surgery. You want to make sure you're maintaining good nutrition with good exercising in preparation to surgery, and make sure that you arrange a support person after surgery to assist with any daily activities that you may need. You will probably need continuous pelvic therapy visits after your surgery, generally on a weekly or bi-weekly basis after the procedure. The post-op recovery is essentially very dynamic. It's also very similar to the previous procedures. In general, for the first 3 days, you are in bed rest. And now for usually on day 3, we ask patients to, we've removed the packing and the dressings, and we'll start dilation generally on day 3. So this is a little bit easier. At home, you're going to need some supplies like gauze, lube, soap, and pads. And on your first office visit, we will proceed with just reviewing, making sure that everything is healing well. And at that point, you have already started your douching and your dilation, and the vaginal dressings and stents are usually removed in the hospital and not during your post-op visit. During the post-op recovery, you will be provided with a set of dilators that we will generally start using the purple or blue dilator and incrementally increase the size over the first year of your surgery. So bed rest for 3 days usually. We generally put a drain that will be removed on day 3 when the packing and the Foley catheter are removed. There is a round-the-clock pain management with acetaminophen. We use pyridium, an antibiotic, and a muscle relaxant as well. Generally, we pay a huge attention using ERAS protocol to prevent the prolonged use of narcotics, also management of nausea by using a scopolamine patch and other medications that we use. Generally, you will be on a low residue diet, and we'll provide you with a list at the time of discharge of what that means. And then you'll probably need to be on a bowel regimen depending on how your bowels are accommodating after surgery. It is very frequent to have diarrhea and loose bowel movements for a couple of months after surgery until sort of the bowel equilibrates and your bowel movements become a little bit more solid after an intestinal vaginoplasty. So on post-op day 3, We go to your room and we remove the vaginal dressings and the packing. We really review the anatomy with the patient and make sure that we do a one-on-one dilation to make sure that you understand the orientation, the pressure, the angle that it takes to perform a dilation. At that point, we generally also show you how to perform a vaginal douching. Generally, this is performed with a small device that we'll provide for you and a little bit of soapy water to irrigate the vaginal canal. At that point, you're free to ambulate and you can shower as well on day 3. Generally, sometimes we use different medications depending on what type of period of time you are in the healing of your vaginal canal. We generally recommend having a mirror during this time. This way you can be part of the process and you can see exactly what's being done from a dilation and douching perspective. And then we always recommend pre-medicating prior to your dilation with an ibuprofen or an anti-inflammatory or muscle relaxant in order to make that dilation the most successful that it can be. Over time, after your initial recovery time of 12 weeks, generally we recommend patients to completely discontinue all medications at that time. So some of the benefits with an intestinal sigmoid vaginoplasty is that you do require less dilation, generally dilating only twice a day. And after the 3-month mark, you're dilating once a day, or sometimes even less. Lubrication is a positive. There will be lubrication. It's usually in the form of mucus, so it's a little bit thicker than the typical lubrication that you see using a water-based gel. Externally, it will look the same unless the patient has significant penile hypoplasia. In that case, sometimes we have to bring the intestine a little bit more to the entrance of the vaginal canal. In this picture, you can see how the intestine has been set up a few inches inside the vaginal canal, so you don't see that visibility of the mucosa. It also requires abdominal surgery, so you need to make sure that you understand that you need to recover from that standpoint. Some of the disadvantages we discussed is lubrication, the need to recover from the abdominal surgery, and that the complications are much more severe than other types of vaginoplasty, as you can develop something like an anastomotic leak. And if that happens, patients sometimes need a temporary colostomy. That percentage of patients undergoing this type of complications is probably less than 1%, but it's something that we need to discuss with patients as well. The risk of prolapse is something that can be present. Also, specific to an intestinal vaginoplasty. The recovery time and the hospital stay is also very similar to other types of vaginoplasties as well. So let's take a closer look at the complications of an intestinal vaginoplasty. So the more common complications that we see are experiencing some urinary spraying, having some drainage and some bleeding during the first couple of months after surgery, or wound healing problems, which generally happen at the bottom of the vaginal canal. But the areas on the left side will tend to generally will self-resolve during the first 3 months of surgery. The other complications that are a little bit less common but are important are things like infection, needing emergency surgery, having an anastomotic leak, having a fistula that is not recognized, which generally leads to a rectovaginal or urethrovaginal fistula, developing a prolapse, and we'll show you a picture of how that looks like. Incontinence is something that we see with patients with weak pelvic floors, generally patients who are older than 60 years old. And if that is the case, we try to recognize the symptoms before surgery and it gets treated with an aggressive pelvic therapy program prior to surgery. And clitoral necrosis, which fortunately is something very unusual, but it's still something that could occur during any type of vaginoplasty. I wanted to share some of the intestinal vaginoplasty results. You can see here a patient on a primary setting, which you can't really see the intestinal mucosa underwent vaginoplasty. It's one of our patients. And the patient on the right side where had complete closure of the peritoneal vaginoplasty and require a revision. This revision have yield to completely resurface the entrance of the vaginal canal using the sigmoid colon. So this junction between the skin and the mucosa could happen very externally, or it can happen a little bit further in into the vaginal canal. And this is the area that can close for. So it's really, really important to continue a very, very good disciplined dilation to prevent this from completely closing. But some of this visibility, I think it can affect the aesthetic result. And it's important for patients to know that if there is a revision taking place or if the patient has penile hypoplasia, the aesthetic result may be very different than someone who is completely opposite. Vaginal prolapse, as we discussed in our experience in our center, the rate is about 12%. The intestinal conduit has the ability to move inside the vaginal canal. and sometimes it starts slowly prolapsing outside, and it could be a very small visibility of the mucosa, which generally we would not do any type of surgery, or sometimes it can be really significant and prolapse a few inches, as shown in the picture on the right side. And if that's the case, it needs to be repaired robotically. Now, this is a patient with a full thickness prolapse. And intestinal prolapse usually can be corrected by different forms of fixation. Generally, it's done by securing a small mesh on the top of the sigmoid colon, or that has been reconstructed for the new vagina. And this mesh is then secure either to the sacral promontory, as shown here, or to the anterior abdominal wall, depending on the laxity. And you can see here, this is the neovagina, and this is the blood supply in the blue arrow. One of the challenges and the reason why it prolapses is if the colon has a lot of this yellow fat deposits or tinea epiploica, it can increase the risk of prolapse. Patients with larger BMI, smoking status, a lot of coughing can increase the prolapse. And one of the challenges is that we cannot anchor directly into the promontory sometimes because the blood supply is just right adjacent to it. So we have to come up with other areas to secure it inside the pelvis to prevent this from happening. Long-term considerations is how often will you need follow-ups? Very similar to the other types of vaginoplasty. Generally, we want to see you on a yearly basis. I think from a lifelong medical considerations is to make sure that you are very consistent with your dilation and douching. It is important that you have the proper colonic cancer surveillance. If you are a high risk individual, you may be required to do that surveillance at a much sooner rate. Usually when a colonoscopy is performed, the same scope is also utilized to evaluate and surveil the vagina, which is now made of colonic tissue that needs to have the proper surveillance, generally starting at the age of 45 for colonic surveillance. And then make sure that you understand some of the risk, the signs to look out for complications. Some of the things that you can see, such as bleeding and drainage early, are things that we experience and we evaluate them, but generally are self-limiting. It doesn't mean that there is a problem, but make sure that you have a closer look, understand the anatomy, and be on the lookout for any suspicious signs of infections as well. And with that, I want to thank you for watching this video on intestinal vaginoplasty preparation. Please feel free to email us any questions, and I hope this helps in your journey. Take care.